Good afternoon and welcome to another satellite seminar from the Institute of Health Studies, being broadcast from the University of Plymouth TV studios here on the Hoe. This seminar has the broad heading Communication in Health, which is one of the research themes of the Institute of Health Studies, and it's an area in which there is considerable scope for collaborative multidisciplinary research. In the studio we have two academics and very active researchers from the Department of Psychology at Plymouth who are going to describe some of the work they're doing. Hopefully in discussion we can explore further opportunities for collaborative research both within the university and with NHS and other colleagues. The programme will be in two parts. First, Fraser Reid will give a presentation for about 15 minutes and then we will have a discussion about teleconsultations. In the second half of the programme, Judy Edworthy will give a presentation on warnings in healthcare, again followed by discussion. We invite your comments or questions at any point. If you have a desk or mobile phone where you are viewing, you can telephone the studio on 01752 233 646, or you could email us direct on tvstudio@plymouth.ac.uk. If for some reason you cannot get through to the studio with your telephone call, you could always phone a friend and ask them to email your question or comment. In the studio to discuss their presentations we also have Maria Benalek, who has a clinical background in nursing and in particular in infection control. So, over to Fraser for the first presentation.
Hello, my name's Fraser Reid and I'm a social psychologist, and for some years now I've been investigating the effects of mediated communication systems on human communication. So today what I thought would be useful is to bring some of the insights perhaps and some of the questions from psychological research to you today by looking at teleconsultations, trying to draw out some of the implications for human communication in the medical encounter that telemedicine and telecare brings. And I want to start with a report published in 1998 by the Institute of Health Service Management, now the Institute of Healthcare Management, because it was such an optimistic and possibly excessively optimistic report on the potential benefits of telemedicine and telecare for the health service. At that point, it was believed that new technologies applied to telemedicine and teleconsultations in particular were proven both clinically and technically, and that there were very clear productivity gains that could be obtained together with increased accessibility in healthcare delivery. But at the same time there were clear concerns that this would bring changes in the way that the health service was configured and new methods of delivering healthcare, and of course management would need to focus their attention on the changes in the way that people work in the health service to achieve this. But perhaps most important for us at the moment was the conclusion that was reached then in 1998 that concerns about the loss of personal contact between patients and their carers were less important than expected at the time, and the evidence seemed to point to rather negligible effects. Now, by now, we have reason to raise some doubts about those conclusions. In a recent review in the Journal of Telemedicine and Telecare, these new doubts are beginning to surface, and the main concern is that the quality assessments that were carried out prior to that date were based on physicians carrying out their own assessments of clinical process and on measures of user satisfaction. And at the time there were rather few studies of the consultation process itself, the actual contact that was made between carer and patient. And even those that were available to analyse showed that most were based on retrospective surveys, which we know to be fallible, where people selectively remember events during the consultation, and that there was clear evidence of known biases in user assessment of the positivity and satisfaction with the care that they receive. So we're now rather less certain about the successes that were claimed in the late 90s. The questions that we need to ask at this stage is to evaluate some of the claims that were made at that point. And one in particular was the claim that the consultation achieved by telemedicine and telecare would be more patient-centered. So we now need to reassess the situation. We need to hold up the consultation to scrutiny as a form of social encounter, and check whether the patient-centred model of care actually is achieved. And we have reason to be concerned about this because there are very significant healthcare outcomes that depend on the quality of the patient-carer interaction. For example, we know that patient satisfaction is very much associated with a warm, non-verbal manner and patient-centred attention. We know that patient adherence and compliance to treatment recommendations are a function of their involvement in treatment decision-making. We know too that objective measures of health and clinical status are often influenced by the quality of that relationship. We know that recovery rates post-operatively, we know that pain experience post-operatively are a function of that relationship between the carer and the patient. We know too that the ability of patients to remember and understand medical advice is a function of the quality of that relationship, and perhaps overall we now know that psychological well-being, levels of anxiety, uncertainty about treatment, coping behaviours are all a function of the degree to which patient care is centred around the concerns of the individual patient. So the question we now need to reassess is whether the medium matters. And here we're in a position, I think, to benefit from more than 25 years of psychological research. But one of the key issues to begin the discussion is that we need to understand what Donald Norman calls the affordances of technical systems. The affordances of a communication system will be the degree to which it supports different aspects of human communication. So, for example, at the top of our list is the modality through which the consultation takes place. Is it purely a verbal modality, or is it a visual and verbal modality, such as a video link? The second affordance, which is most important, concerns the degree of interactivity. Does the interaction between physician and patient take place in real time, i.e. is it synchronous, or does it take place intermittently over time, at a time and at the pace desired by individual patients? If we take telephone consultations, for example, well, clearly these are verbal and interactive. But compare those with electronic mail and texting exchanges, clearly these are verbal but less interactive, asynchronous. And of course, video links are an example of a visual verbal modality which is highly interactive, and explorations of the applicability of these are already being carried out throughout the country, in particular in Scotland. So with these affordances in mind, psychologists generated a series of hypotheses which they then put to experimental tests. And the first and most obvious hypothesis they called the bandwidth hypothesis. Essentially, the idea is that the more information a communication medium can convey, the closer it gets to being like actually being present with another person, then the more likely communication will be effective and efficient. So amongst the different affordances of communication media, interactive visual verbal media should be best overall. Well, is that the case? Well, the answer is surprisingly perhaps no. Dozens of studies have shown that for information giving, the exchange of information, interactivity matters, but modality doesn't. In other words, being able to get instantaneous feedback from another person about whether they understand you, what they understand, is more important than being able to see them or to see what they're doing. And in fact, it means that there's no obvious advantage in adding a very expensive visual channel to a speech channel. And as an aside, this in part explains the failure of the video phone in the 60s, the poor take-up of video conferencing systems throughout the 70s and 80s, and possibly also the poor prospects for 3G mobiles, which allow conversationalists to see each other as they speak. So this nudged psychology to make a more precise and more detailed analysis and a set of hypotheses, and that gave rise to the cognitive cueing hypothesis. This essentially suggests that instead of there being some generalized effect of communications medium, it's very specific and affects particular bits of information that are exchanged during the consultation. And under this idea, non-visual media should disrupt conversational patterns. We know that gaze is a very important part of the regulation processes that go on inside consultations, and that gaze signals the end of a speaking turn and the transfer of the initiative for the conversation to another person. Speakers tend to look at their listeners more at the point where they are ending their contribution to the conversation. So the first question one would have to ask, well, maybe the lack of visual access would disrupt the way people organize their speech and how they talk to each other. Well, again, psychologists were disappointed. Here, there was little evidence, certainly by looking at telephone conversations, that people fail to organize their speech in a regular and orderly way. In fact, telephone conversations are now known to be much more regular, much more orderly than face-to-face communications. Fewer instances of simultaneous speech, fewer interruptions. Why? Because people who use the telephone get used to compensating for what they can't do by looking at the other person. They regulate the way they take turns to speak, they ask more direct questions and much more formal methods for controlling the exchange of speaking turns. So another question that the cognitive cueing hypothesis gives rise to is whether or not the lack of visual access might make it difficult for people to achieve joint reference. Now, joint reference is a term that refers to the ability of people to identify, to locate, to describe something in their shared environment. So when a patient says to a doctor, I've got a pain here, then the doctor looks to where the patient is pointing. Now, clearly, if you can't see the patient and the patient can't see the doctor, that process must be disrupted. Well, here we can say, yes, that is in fact what occurs. The lack of video access does disrupt the degree to which joint reference is achieved, and we have experimental results that show that it takes longer, with many more speaking turns, to achieve understanding about what is being referred to in the environment. So we're beginning to get some evidence that there could be a disruptive effect of a lack of visual access that may affect some of the health outcomes that we know to derive from a patient-centered consultation. But it's when the psychologists began to look at what they called the social cueing hypothesis that results, very much more subtle results, began to emerge. The social cueing hypothesis basically argues that the lack of social and personal feedback from another person as you speak to them must disrupt the degree to which you understand them, the degree to which you can be persuaded by them, the degree to which you can reach agreement with them, and the processes of compromise and consensus. And the first hypothesis was that non-visual media will therefore be less expressive. You can't see the other person, you cannot gauge their conviction if you cannot see the attitudes and emotions that they're expressing. Here, there is very clear evidence that a lack of visual access, for example in telephone conversations, does affect the extent to which people express their real emotions. Phone calls are typically more task-focused and more impersonal, less revealing of people's true feelings than are face-to-face conversations, and interestingly, even than text exchanges by electronic mail or online discussions. Here, people seem to be more disinhibited, more ready to be candid and open about their feelings than a telephone conversation with a colleague. Finally, we would expect, therefore, that a lack of social feedback would disrupt important processes such as the ability to reach a decision. Well, yes, it is true. We have evidence from our own laboratories that online conversations and telephone conversations make it more difficult for participants to reach mutual agreement, to gauge the strength of convictions of their colleagues, and to achieve compromise over these media. So let's draw this together. Okay, I put before you some conclusions that look as if they should apply to the consequences for teleconsultations, some implications that we can draw out. Well, the first is that, yes, the medium does matter. It's now clear that different affordances of different media do impact upon the quality and the content of social encounters, and this therefore must be true of the medical encounter too. Secondly, could we be looking at the prospects of a trade-off between improving access to healthcare but accepting a reduction in the quality of that care, because we know that, for example, telephone conversations are less personalised, more formal, less revealing, that surely this must mean that individualised care would be harder to achieve. The other side of the coin, of course, is that health professionals who are consulting clients and patients through telemedicine media must therefore be less confident about the decisions they reach. And would this lead, therefore, to overdiagnosis and over-referral, and a self-defeating effect, if you like, of increasing the load on other parts of the health service? And finally, I suggest to you that the prospects for patient-centred care through telemedia are probably less likely with the evidence that we've got before us. So the conclusions we would reach would perhaps be more sceptical than those that were reached in 1998. Thank you.
Okay, well, thanks very much indeed, Fraser. That's very interesting. So now we'd like to hear from you. Remind you again that the telephone number is 01752 233 646. So do please phone us with your comments or questions. If you want to email us, it's tvstudio@plymouth.ac.uk. And in the meantime, we've got 15 minutes now, or just under 15 minutes before Judy Edworthy goes on to the second part of the programme. So do come in with your comments and questions now on this part of the programme. And Fraser, can I kick off? I mean, this whole issue about the trade-off between the access and sort of the quality of care, yes, is important, I think, and interesting, because I mean, if clearly, I think the telephone consultation with, yes, NHS Direct is improving access. I mean, it's whatever it is, 18 million telephone, yes, calls, or, yes, whatever a year. Yes. So in that sense, it's improving the quality of access, and quality of access obviously is part of the quality of care. But will there be some people, do you think, who will now become disadvantaged as a result? Yes. I mean, I was interested with the telephone, your comments about the telephone, because in my sort of lay observations of, yes, people, of yours, yes.
We all have those.
Yes, yes. Women are much better at multitasking than men are, right, in conversations. I mean,
probably true.
I mean, my mother-in-law and her sister can both talk exactly all at the same time, completely. Yes. Have one conversation where they're both talking, yes, and I just can't do it.
Yes, now, yes.
Will they be disadvantaged by a telephone?
Well, as it happens, I mean, this is more than just a rumour, an ugly, yeah, rumour. It is probably true that men and women do use the telephone in different ways. There is some evidence coming out from a study on the use of telephone consultations to follow up in asthma care, long-term chronic conditions. And the evidence, as yet unpublished, shows that men are far more formal in the way that they speak to the nurse who is caring for them at the other end of the telephone, and they don't reveal as much information about their current condition as women do. So I think there are clear differences in the way that people become accustomed to using the phone, and the general conclusions that are reached clearly do differentiate between users.
But presumably, though, I mean, men are also perhaps less revealing in a face-to-face consultation as well.
They may well be.
You need to know whether it actually improves it. I mean,
that work has yet to be done. Yes. But I mean, in general terms, the question of access is an interesting one. I mean, accessibility of healthcare probably means to most people that they could have a conversation like the one they have with their GP at any time of the day, virtually from any location. Yeah? In fact, the evidence that I put before you suggests that if the call centre approach, really, or the objective of telephone call centres, is to triage and refer emergency cases for treatment if that's the need, or refer to GPs and other departments, then that's fine, and telephone conversations are perfectly adequate for that. But if patients expect a more individualised form of care, if they want the person they're speaking to understand that they feel ill and want them to draw out more about their concerns, then the telephone consultations will not do that, and there may be unwanted side effects where expectations are unfulfilled.
We have Dr. Man Chung, who I believe you will Fraser will well know, yes. Colleague from Department of Psychology. So, Man, do you want to put your question, please?
Yeah. Hi, Fraser.
Hello, Man.
Well, thanks for the talk, which is very stimulating indeed.
Yeah, thank you.
The real question here is about whether or not patients can actually improve their psychological or general well-being by engaging in this sort of consultation.
Yes.
Do you know of any studies which might have addressed this question? Or?
Well, there are a few, that not sufficient to draw the conclusions that are driving the provision of the service, I would say. They generally do show that patient expectations are not readily fulfilled through telephone consultations. Objective health outcomes remain to be measured, and I think we need long-term studies. I mean, there are, obviously the NHS Direct service is being investigated as we speak, but there are other forms of teleconsultation that are being launched in the United Kingdom. One study in particular is actually a video link set up in northeast Scotland, where a nurse attends a patient's home and mediates a consultation over a video link with a physician many miles away. And there are very clear instances of improved health outcomes from that particular project. But I have to say, it doesn't achieve the objectives that are held out for NHS Direct, because it is resource intensive to the nth degree. It's very expensive to set up and to administer. And it may be more expensive in the long run than getting a taxi to take the patient to the nearest GP surgery. So there is some evidence coming in of clear health outcomes, objective health outcomes being achieved by teleconsultation, but we're not sure yet whether those are resource efficient in a sense or cost effective. That remains to be seen.
Yeah. And I suppose another question, which is
Sure.
related to the evaluation of NHS Direct, for example.
Sure.
Obviously, the patients who use NHS Direct tend to suffer from, I don't know, some kind of physical health problems
Sure.
or whatnot. But we know that some places now, or some researchers now, are beginning to do research on the effectiveness of using writing therapy via emails for people who suffer from some kind of more sort of psychological problems. So I'm talking about sort of email counseling and that sort of stuff now. Do you know of any studies which might have evaluated?
Oh, there are numerous studies, Man, that have shown that online keyboard conversations, I mean, they're not directly related to the investigating healthcare delivery, but online keyboard conversations are often incredibly deeper and more intimate, more revealing, more disclosure takes place in these conversations than their equivalent face-to-face meetings. Okay, so there are clear benefits that we could anticipate from sort of web-based or email-based or online or instant messaging-based systems for that kind of healthcare. Certainly.
We have an email that's come in from Annie Jenkin in Plymouth. She says, hello. We now live in a very multicultural society. Is there work to suggest that teleconsultations inhibit people where English is not their first language?
I don't know of any studies so far that could answer that question, and it would be difficult to speculate around this until we were able to see what provision for multi-language speakers is available for healthcare delivery.
And we've got an email in from Bodmin, which says, clearly there's a lot of work going on in teleconsultation and research in this area.
Yes.
But given that NHS Direct is already up and running, and they're also just about to implement an email clinical inquiry service,
yes.
Is it actually too late? I mean, it's a bit like doing research on whether or not we should have mobile phones.
Yes,
what should
they're
we be
already
doing?
here. Well, I think my answer to that would be yes, except NHS Direct is up and running. but let's change the expectations about what it might deliver. I think that if patients come to it expecting more than it can deliver, there will be more disappointment and, than is necessary. From the research that we have to hand at the moment, it looks pretty clear that advice giving, possibly general advice, and referral management is probably best dealt with on the telephone, or most effectively dealt with through telephone call centres. But as I said earlier, the danger is that patients come forward with expectations that they get the same level of individualised attention and care that they can get with their GP, and that is unlikely to happen.
So, Maria, do you want to?
Well, I was very interested in the difference between the telephone and the email.
Yes.
I thought that was very interesting.
Yes.
And I wasn't aware that there were plans to develop this email consultation with NHS Direct, but it seems to me a very logical progression.
Yes.
If the expectations aren't being met by the telephone consultation, that little bit more may be available through email.
Yes. I think that's a very positive move. I'm not very familiar with the developments that Mann was referring to, but clearly they do open up an alternative channel which produces quite different outcomes, different affordances, and I remember many years ago when the Mighty Micro was new on the scene. Almost overnight it was discovered that patients would be much more open and reveal more about their own personal concerns to a computer than they would to a real person. Now, little perhaps has changed since those days. And I think we need to learn from that lesson.
In alcohol, isn't there? I mean, alcohol, the cage questionnaires on keyboard, people regularly admitted to drinking more alcohol than they did face to face.
Right, right.
But it'd be interesting to know whether that will continue, though, because I mean, I think, you know, if you go back to the 70s, 80s, people tended to think they were talking to some sort of great god in the sky.
Yes.
Whereas now, I think people are getting a lot more clued up about it, and it may be that the actual difference may...
Well, that may be true, but the advantage of sort of keyboard communication is that you don't have the immediate presence of another person who, for all their benefits, may well be a distraction as well as a positive advantage to have somebody sitting opposite you. Okay. So yes, tap, with all that information pouring in to you, it can drive you away from your concerns. Whereas if you can sit down in the cold light of of early morning and tap away on the keyboard, then perhaps more can be revealed through that means.
We've just got one more email which we can take here from Plymouth, Miriam McMullen. She says, you mentioned possible gender differences in the use of telemedicine. How about age differences?
Well, I think the same study that I was referring to regarding asthma care also was picking up differences in the readiness with which different age groups take to new technologies and new communication technologies in particular. I'm not able to give specific information about the results. As I say, they're not yet published, but I think age differences are yet another factor which will come out in these studies, certainly.
Okay, well, thanks very much indeed, Fraser, and thank you for the questions and comments on that part of the seminar. We're now going to move on to the second part of our seminar, which is Judy Edworthy talking about warnings in health. So, Judy.
Yes, hello. Well, I've been working in the area of warnings in various applications for a number of years, and a lot of what we've done is relevant to healthcare. And what I'm going to do today is not so much talk about the theory, but just to give you some idea of the kinds of work that we've done and how it could be applied. Fraser was talking about the medium through which you present information earlier. Well, we've been concerned with the differences between visual and auditory warnings. And there are some occasions where a visual warning will work better than an auditory, but mostly auditory warnings that you hear, will work better. So what I'm going to do is talk a bit about auditory warnings first, and then talk about visual warnings afterwards. I have some auditory and visual aids, which I have on the desk over there, which we can play later, and I also have a cigarette packet here that I want to refer to. Alarms in healthcare are they're an enormous problem actually. In the intensive care ward, operating theatre, they can be very distracting, they can be non-informative, they have all sorts of bad features. And the consequence of this is that people turn them off. Okay. I've read studies where, for example, in an intensive care ward and the recovery room, there are something like 50 warnings in total. That means that there are too many. No person can be expected to remember that number and to deal with them when they're heard. You can't tell them apart, mostly because they're badly designed. They all sound very similar. They're badly designed acoustically. That means that it's hard to actually tell where they're coming from, what you should do when you hear them, or indeed whether you can hear them, or they could equally be too loud. Another problem is that they're not matched to the situations that they're signalling. For example, sometimes infusion pump alarms are very shrill and loud, even though you don't really need to do something immediately. On the other hand, a ventilator alarm can be much less acoustically urgent. Now, if you know what those alarms mean, that's fine. If you don't, then there is nothing in the warning that will help you to work out which problem you should attend to first. So there are a number of problems, and as far as I can tell, there haven't been huge numbers of steps to actually correct this problem. You get the odd new set of alarms that have been designed for, say, anaesthesia, which are an improvement on the old ones, but they're generally still not very good, and the whole set of warnings tends not to work very well because they're designed bit by bit. A new piece of equipment will come in with a different alarm on it, or the same alarm. Even more worryingly, you can have people who make medical equipment and they use their in-house alarm, so you can have a ventilator and some other piece of equipment made by the same manufacturer with the same alarm sound on. Now, what you really need to be able to do is to identify the problem, not who made the equipment. So there are all sorts of psychological and conceptual questions about how alarms are designed that need looking at. In terms of the design, I mean, the continuous tone, the heartbeat, the flatline sound, which I've got and I can demonstrate, is the worst sound ever. If I had to give a talk on how not to design an alarm sound, that would be the one that I would pick to talk about, because it has everything bad about it. You can't tell them apart, you can't localize them, they're acoustically poor, so other sounds can mask them and so on. All these problems are actually solvable. And to a great extent, psychology and psychoacoustics and engineering has solved these problems. They have yet to be implemented. Now, some of the research in the area has already shows us how we can make a number of improvements. We can make them better acoustically. This is not really a psychological problem. We can design warnings in such a way that they will be easy to localize. You will hear them. They won't be too loud, they won't be too quiet. Obviously the noise in hospital wards fluctuates, but these days actually you can get systems that can respond to the ambient noise. That means that they can get louder or quieter depending on what's going on. You can get PA systems that do this. So you can make them better acoustically without too much difficulty, and it's not expensive, despite what... If you can buy a birthday card that plays Happy Birthday for £2.50, you can put a new alarm on a piece of expensive medical equipment. Now, the area that I've worked in particularly is that you can produce appropriate urgency with alarms. That means that you can have urgent alarms signalling urgent situations, and you can have non-urgent alarms signalling non-urgent situations. Now, this is a basic response of the auditory system, is to tell you how quickly you need to move, how severe the situation is. Your hearing is your warning sense. Now, this has huge benefits because it means that even if you don't know what the alarm sound means, you can respond in an appropriate way. You know how quickly you need to respond. So if you hear a very urgent alarm, you can go and deal with the problem straight away. If it's a less urgent alarm, then the natural thing to do is to go and look to see what the problem is, look at a visual display, go and look at the patient. But you don't need to rush. So we can do that. And I know that some medical situations they're context dependent and they can vary. Sometimes something might be important, sometimes it might not be. But if you have an intelligent alarm system, which also monitors information coming from the patient, you can produce the warnings accordingly. So you can produce them online, in fact. Now, there isn't any. I don't think there's any piece of apparatus or piece of equipment that can actually do this. It could be done. So we can produce urgency. We know exactly how to do that. We've done lots and lots of work on this. It's exactly the same thing as when you listen. If you watch Psycho, the film Psycho, it's terrifying before it's even started, because the music has induced that kind of mood. And in fact, the composer Bernard Herrmann did all the things that an auditory warning designer would say do to make your warnings oh, your sound, urgent. It's terrifying. Before you even know what it's about, it's frightening. Okay. Now, alarms don't need to be that alarming. I think people tend to believe that you must have something really shrill and attention-getting, but actually what that does is to panic people, especially if they don't know what it means. Now, possibly the biggest problem with alarms is there are just too many of them. And, of course, people worry that if you take some away, then something will go wrong and somebody will get sued or somebody will die or something will happen. It's not necessarily a problem. You can reduce the numbers by having some kind of rationalisation or some kind of standardisation. Now, 20 years ago, believe it or not, there was a move to rationalise hospital alarms so that you only ever had 7. And you had an urgent version of each alarm and you had a non-urgent version. And the point about this is that there are actually only 6 or 7 ways a patient can actually die. The equipment changes all the time, but the people don't. So let's have the alarms, let's have the functions of the alarms related to the person, not the equipment. So, for example, you could have a temperature problem, you could have a heart problem, you could have a ventilation problem, and you run out of problems quite quickly, actually. And you just have the same set of 7 alarms. Now, I was involved in, a long time ago, a British Standards Institute and a European and worldwide standard on exactly this thing. But there was such resistance by the manufacturers who wanted to use their own alarms that it never actually took off. And I believe now the standard is very much, well, you've got to have an alarm on it and it can be urgent or non-urgent, but we're not going to tell you exactly what the alarm should be. Now, the point is, if you standardised, then if you move job from one hospital to another, you would know what the problem was when you heard it. So there are ways around the number problem. You don't have to have different alarms for each situation. What you can do is have general alerting sounds. And then when you don't need to respond immediately, you can go and look and see what the problem is. Because hearing is about responding immediately, not about... in many cases, you can go and look afterwards. So our work has been particularly on perceived urgency in auditory warnings, and we have a lot of work done in that area. We're still looking at people's behavioural response to urgency and all sorts of other things related to that, and many more theoretical ideas related to auditory perception in this area. But what I want to do now is to turn to visual warnings. I hadn't realised, but hopefully we can see this. It's a cigarette packet, believe it or not. And it's got a warning on it. It's got a huge warning on it. I love it. I just wish that they'd paid me loads of money to design this myself. It says, it's much bigger than the old warning, it says, smoking seriously harms you and others around you. It's in big black writing, has a big black box around it. On the side, it tells you exactly what's in it, how much tar's in it, and carbon monoxide. On the back, in bad English, it says, in same big black writing, smoking may reduce the blood flow and causes impotence. Now, we know that when these warnings were introduced, the number of people phoning the helplines to try and give up smoking increased enormously. And that made me feel quite good, because this is an area I work in. It's nice to feel that what you do is actually useful. I didn't play any part in this, but there are all sorts of questions you can ask about this. What is it specifically about this warning that's changed people's behaviour? Why has it suddenly made them more keen to give up smoking? Well, it could be any number of things, and I've listed some of them here. And these would make nice research projects. For example, it could be something as simple as the design features. It could be that it's in a much bigger font now. There is work on that. It could be because it's in black. Black is the colour of death. It could be even the border, those kinds of things. It could be something just to do with the way the thing has been designed. Okay, so that's one. That's one possible explanation for the effect. A second one could be what we call habituation in psychology. This is a huge area where basically people keep being shown or heard, or they hear the same signal, and then it changes. So what people do with warnings is that they see the same one day after day. They think, oh, it's the same, same old warning, nothing's happening. And then they buy a packet of cigarettes, and there's a huge warning on it, and it gets their attention. And they change their behaviour as a consequence. They could also think, oh my God, it's much bigger now, so it must be more serious. People really do think things like that. It could also be, a third factor could be the explicitness of the message. It's a very explicit message here. The one on the back, smoking may reduce blood flow and cause impotence. It's telling you 2 things that will happen to you if you smoke. It's not just saying it's bad for your health. It's saying precisely how it can be bad for your health. So explicitness is another factor, and that's another area that has been looked at, not by me, but people have done work on explicitness. And of course, a fourth factor could be it could be entirely coincidental that people have responded more to these warnings. Because what could have happened is that people just know more about the effects of smoking on health now. So it's coincidental. This has just kind of nudged them in the right direction. There's another thing, actually, that I hadn't noticed, because I don't smoke myself, and I hadn't actually seen one of these packets, that I got one of somebody yesterday. What I really like is this: smoking seriously harms you. It's using the personal pronoun, you who are just about to smoke this cigarette, and others around you. Now, we've done research in another area, which I'll talk about in a minute, that's shown that when you use the personal pronoun, it does increase people's level of compliance. So it's got lots of features, very good features, this. And there are things, you could apply this to lots of other areas, but you could do projects where you look at specific variables and change one of them at a time, rather than having a kind of confounded experiment, which is what this is, where lots of things change at once. Now, not doing that in itself won't make people comply with warnings. And what you need to bear in mind is that compliance with warnings is a cost-benefit analysis. Now, in psychology, people model this cost-benefit analysis. There are various models. There's one called the theory of planned behaviour. There's one called the subjective expected utility model. These are all models through which you can model people's behaviour in social contexts and other contexts. And they take account of the costs of complying. Of course, everybody wants to give up smoking, but the cost is too high, i.e. they're addicted and it's just too much of a struggle, or something like that. If you want people to comply with warnings, you have to consider not only, you can tell them what the benefits are, but you can also, but there are costs. So, for example, if you have to comply with a warning to wash your hands, for example, it takes time and effort. And if you tell people to wear protective equipment, they have to buy it. These things cost money. And sometimes there are adverse effects. If it's it's nicotine withdrawal, it's obviously an adverse effect. And there are social effects too. People smoke for reasons other than, to look stylish. If they don't smoke, they might be laughed at or something by their friends, especially young people. But there are other things, like if you have to wear really stupid equipment, people won't want to do it. You have to make it so that they will want to comply. Actually, these social effects are very large. I just wanted finally to talk about some results of a project that we did, Liz Hellier and I, my research colleague, on pesticide labelling. This was funded by the DTI and the Health and Safety Executive. And we looked at different ways of labelling pesticides, and we looked at amateurs and professionals. And this is an area, again, that hasn't really been looked at, the different way that professional people who have to do things, and their job depends on them doing it right, and amateurs who just would use pesticides, for example, in their leisure time. What we found was that when you use the personal pronoun, you say to people, if you don't wear protective clothing, it will harm you, or something like that. It does increase the amount of compliance you get out of them. Now, for whatever psychological reasons, so that's another matter. Also, we found, and other people have found this, is where you put the instructions matters too. So, if you put the safety instructions in the safety part of the pesticide, people tend not to look at it. But if you put it actually in the instructions for use, people will comply with it more. Right, so in the directions for use, you also have the safety instructions, rather than having them in a separate section. We found that too, and we also found that there are quite big differences between amateurs and professionals, which we as psychologists can model theoretically and kind of in other ways. But the point is, practically it matters, and we found that professionals comply more. Also, they'll do things like they will look at additional leaflets, all these other things. But amateurs basically are fumbling in the dark a lot of the time. They won't do what is asked of them. They don't behave in a kind of organised way when they deal with these products. So I think I need to just finish by saying there's lots and lots of research on warnings, and a lot of it is relevant in healthcare, from very simple things like signs telling you to do something, up to complex, intelligent alarm systems. So,
okay, thanks very much, Judy. Well, while Judy comes back here to join us, just to remind you that now's your chance to phone in on 01752 233 646, or email the studio on tvstudio@plymouth.ac.uk. Clearly, what you've been doing today, Judy, is very, very relevant. There's all the stuff in the newspapers today about the sexual health problems, in Plymouth and around the country as a whole, and trying to get the proper warnings embedded within health promotion is really important, and infection control. Maria.
Absolutely. The thing that jumped out and hit me, Judy, listening to you, was this concept of habituation.
Mm-hmm.
And what we try to do in infection control is get people to comply to very, very basic procedures. Basically, hand washing is what we're talking about. And we've tried poster campaigns, and we've tried this, that, and the other. And people very, very quickly, they have very little impact very, very quickly. Very interested in that aspect of your work. And
it's interesting because although there's lots of psychological research on habituation to visual stimuli and auditory stimuli, there's very little actually on habituation to warnings. Now, we did one study where we just basically showed people the same warning and measured physiological response, and then replaced it with a new warning and found that the various measures increased. But we still haven't done stuff looking at actually how it affects behaviour. There's plenty of scope for work. Yeah. It's clearly a very important issue, and we know things like, if you present it if you change it on a regular basis, people will habituate to the rate at which you make the change as well. So you've got to keep surprising them.
I like the idea of the auditory warning. Not quite sure how practical that will be with hand washing and infection control.
But it's really funny because the other day I had a cereal packet and it said, if an alarm goes off, you've won a prize. So you can clearly put alarms anywhere. You can put them on. I used to have a joke about putting verbal warnings on medicine bottles, but it's doable now because it's very cheap to do. It could really a question of a few pence to do this, and that will have an immediate impact. It'll only work once, but it will have an immediate impact, and we know that people comply more to auditory warnings than to visual warnings. And I used to think it was my joke, but it's not a joke anymore. You can do this now. So there's plenty of scope. It sounds bizarre, but actually you could do it.
Absolutely. When you think of the cost of healthcare acquired infections running about £1 billion a year to the health service and 5,000 deaths a year, anything is really worth looking at, isn't it?
Yes.
I've got an email in from Exeter which says that how do you compare the situation in the intensive care unit, the ICU, with the airplane cockpit? And presumably one of the problems is that in an airplane cockpit, one manufacturer has the responsibility of putting all the warnings together in a sort of coherent format, whereas maybe in the ICU, because there are many different manufacturers, that's not possible. Is there a role for some sort of company which acts as an intermediary who deals with all the outputs for the alarms in an ICU?
Yeah, I mean, I think actually cockpits are quite a mishmash as well, actually more so than you'd imagine. You can have equipment for all sorts of people. But also you could manufacture a kind of universal bus or something where you could collect pieces of equipment, and you could impose an alarm system on any set of equipment. So
that nobody has their own alarm, they just give you a signal. Yeah.
That's right. They provide the signal, and then the alarm comes from a universal warnings box or something. That can be done, and I think there are moves to do that. Actually,
are there moves, Judy, towards industry standards in alarms, so that manufacturers will be compelled to agree to use particular alarms for particular
purposes? It tends to happen, the way standardisation happens is not through committees of the BSI and so on. It's by a big manufacturer making something. It seems to improve things, and other people will adopt it. Like, for example, Schreiber in the US have a system, and I believe that Hewlett-Packard have some kind of system.
Now, we've got a telephone call from good old Man Chung again. So, hi Man, that's your phone call?
Yes, hello. Thanks, Judy. It's a very stimulating talk. Can I just ask a question which might be relevant to Fraser as well? Do you know of any studies which look at the relationship between using warning signs and the changes of consultancy behavior? What I mean is, would doctors sort of change their consultancy behavior as a result of the development of these warning signs? Like, would they use these warning signs more and present these warning signs to the patients more? Or even would they sort of change the way in which they organize their GP practices by using these warning signs? Like, they might put more leaflets or warning signs leaflets in the surgeries and so on. Do you know of any studies like that? Or
No, I don't actually. I didn't.
No, I can't think of anything that is directly relevant to that man, but it clearly is an issue that GP practices must deal with on a daily basis, because my recollection of the GP surgery is that it's plastered with signs. Not necessarily all warning ones, but the informational signs and advisory signs, information on places and locations and times and so on. So a surgery seems like an ideal place outside of ICU to investigate the use of visual and auditory information.
There has been some research on looking at clutter, visual clutter with warnings, and they find that, of course, the more you have, the less likely people are to comply with anything.
There's certainly, I mean, work being done, isn't there, on the smoking prevention, and that if that's given by the GP to and the GP hands the leaflet over to the patient, that's been shown to be more effective than if the patient's just picked the leaflet up on the wall. There has been that sort of work. I know, man. Yeah, I've got another email just come in. So questions, two questions from Miriam McMullen in Plymouth. Concerning the cigarette package design, if people smoke less due to this design, who pays for it? I imagine it's not the cigarette company.
Sorry, I don't quite...
It's if people smoke less due to this design, who pays for it? I imagine it's not the cigarette company. I suppose what Miriam's getting at is the sort of relationship in a way between regulation, who making the cigarette companies put warnings on, and whether they determine it, because the cigarette companies themselves presumably wouldn't be doing research into how best to warn people not to smoke.
Well, no, and also when they do publish research, then the people don't believe it. You know, like the recent research that was done that said passive smoking wasn't bad for you.
Yes.
The second question was about the pesticides. Do you know the reason why amateurs behave differently to professionals when using pesticides? So say a bit more about that.
Well, the problem with this particular area is there's not a great deal of theory that you can actually use to inform it. There are things that we do know things about the differences between novices and experts. But what we've tried to do is to we look at people's behaviour in terms of whether it's what we call skill-based or knowledge-based or rule-based. Now, what we find, and these are different levels of people do. When you operate at a skill-based level, it's basically automatic behaviour. When you operate at a rule-based level of behaviour, you can follow like rules that say if this, then that. And you operate in a knowledge-based way only when you can't do any of those things. You have to call in your own knowledge. Now, at every level, the professional has more of those things. They know more. They have more skills. They have lots of if-then rules. And if they can't do the task, they then will start to look. It's basically because I think they just know more and they know how to behave. And of course, they have constraints on them, like, you know, they could lose their job. They could get into trouble if they didn't do what's required of them. Amateurs, of course, in reality, when you do your job, you will be provided with the equipment you need to comply, one hopes. Whereas amateurs, if they're told to don some very expensive protective clothing, they won't have it. And they'll just think, oh, we'll spray it anyway.
And they will be
there are no
less
consequences.
familiar. Yes, they will be less familiar with the consequences of not complying to instructions, whereas professionals will know what will happen.
Now, I know, Judy, you've got some.
Well, I had some sounds.
Let's hear these sounds.
Well, I was going to play my flatline sound, which is, you know, the worst warning ever. I mean, I know that it has a meaning because we all know what a flatline means, but.
It's a silent one today, is it?
That's a very, very bad warning.
Yeah, that of course is almost the.
You know what it means.
The ER one, isn't it?
Yeah. I mean, we all know what it means. That doesn't mean to say that it's not a bad warning, though. In fact, many of the traditional warnings that we use are actually quite good in the sense that we have a kind of what we call a semantic association. We know what it means. Acoustically, it's bad, but it has a meaning for us. So we can adapt those warnings to actually make quite nice ones. For example, this is. We know what this is. We know what that is. We know what that is, but it's actually quite a badly designed sound. What you can do is you can modify it. One of the big problems with alarms is that they come on and they stay on. Now, that's the worst thing that could happen when you're trying to communicate. For example, if there's a fire, what you don't want to do is you have to shout over the alarm. You actually need to communicate. It's perfectly possible to have alarms that come on and go off again and then come on. Yeah, have intermittent alarms, because also they work better as alarms because the auditory system responds much better to change than it does to continuity. So you can do all these things. You can modify well-recognised sounds that have meaning for us, so that they're acoustically, psychologically better when we still know the meaning. There are ways of doing that.
Do you think we can put sounds in the toilets to get people to wash their hands?
Well, that's where my brain is running. I'm thinking, could we set up some system where, if somebody walks through a door and they haven't washed their hands yet, an alarm goes off. I mean,
well, this is
who knows?
Ubiquitous computing is an emerging area where computers as small as barcodes and adhesive strips can be attached to devices. So if somebody doesn't touch the door handle with a wet hand, then the alarm goes off.
Yes, I think sometimes it's better to stop the behaviour. I mean, the warnings are really a last resort. Much better if you can change the situation so they have to comply. So, for example, you can, for example, a nozzle. You can have a nozzle on a piece of equipment. If you don't want them to use it for more than 5 seconds, rather than telling them not to, make it so that it hurts after 5 seconds. They have to take their finger off. Yes. That will work too. So, where you can, try and modify behaviour in a different way.
That's got an email here from Dean Whitehead in Exeter, who he says, my experience of men's toilets on motorways, I don't really want to go into that, but, is that the warnings are a complete waste of time. The number of men who go in to have a pee and then leave to eat their sandwiches without washing their hands is mind-bogglingly horrible. What can be done?
Well, it's not an area of expertise of mine.
You can reassure Dean that it happens in ladies' toilets
presumably
too.
the now wash your hands sign is a complete waste of time, isn't it? I mean,
well, it's also to do with people's perception of risk. They think, well, there is no risk. It's a very insidious kind of thing, and that's another big psychological area. People's perception of risk, of the size of a risk, and for example, there are areas like GM food labelling and the BSE scares, and all these things are interesting examples of people's perception of real life risks. And in the case of some of them, you don't even know what the risks are. GM food, you don't actually know what the risk is.
We'll have somebody avoiding BSE infected meat, but smoking 60, 70 cigarettes a day.
Exactly.
Yeah.
Which actually, in the second part of his email, it says, the evidence from public health suggests that some of the more structural changes, such as banning smoking on buses and trains, in cinemas and at work, probably have more effect on the numbers thinking about quitting or actually quitting than health warnings on cigarette packages.
No, I agree.
So how much effort is it worth putting into the design of such warnings as opposed to other public health
well, I mean, I think it's worth doing. It may, I think there are things, a way that you can modify, making somebody feel socially isolated because they're smoking and none of their friends are, will work very well. But if it has an effect, then why not? How much money are you prepared to put into it that will save 1 or 2 people's lives? If a big black warning on a cigarette packet stops at least one person giving up, then that's
do you think that, I mean, you mentioned the personal pronoun. Presumably if we can personalise it even more so that when somebody that's right, yes,
and their health status.
Simon, thinking of somebody I know, this will affect your health, and it will affect your, your partner's health as well. So maybe that will be more effective. Well, I think we're coming to a close. If there's no more questions coming in, we've got about 1 minute to wind up. So I think that's all the time we've got time for. I'd like to thank very much Fraser Reid, Judy Edworthy, Maria Benalik, and of course all of you for watching and participating in this programme. But don't go too far away, because in 1 hour's time at 2 o'clock we've got another programme. In that programme we'll be discussing clinical outcome measurement in health. So goodbye for now, and hope to see you soon. Goodbye.
New technologies applied to telemedicine and teleconsultations in particular were proven both clinically and technically, and that there were very clear productivity gains that could be obtained together with increased accessibility in healthcare delivery. But at the same time there were clear concerns that This would bring changes in the way that the health service was configured and new methods of delivering healthcare. And of course, management would need to focus their attention on the changes in the way that people work in the health service to achieve this. But perhaps most important for us at the moment was the conclusion that was reached then, in 1998, that concerns about the loss of personal contact between patients and their carers were less important than expected at the time, and the evidence seemed to point to rather negligible effects. Now, by now, we have reason to raise some doubts about those conclusions. In a recent review in the Journal of Telemedicine and Telecare, these new doubts are beginning to surface, and the main concern is that the quality assessments that were carried out prior to that date were based on physicians carrying out their own assessments of clinical process and on measures of user satisfaction. And at the time there were rather few studies of the
Good afternoon and welcome to another satellite seminar from the Institute of Health Studies, being broadcast from the University of Plymouth TV studios here on the Hoe. This seminar has the broad heading Communication in Health, which is one of the research themes of the Institute of Health Studies, and it's an area in which there is considerable scope for collaborative multidisciplinary research. In the studio we have two academics and very active researchers from the Department of Psychology at Plymouth who are going to describe some of the work they're doing. Hopefully in discussion we can explore further opportunities for collaborative research both within the university and with NHS and other colleagues. The programme will be in two parts. First, Fraser Reid will give a presentation for about 15 minutes and then we will have a discussion about teleconsultations. In the second half of the programme, Judy Edworthy will give a presentation on warnings in healthcare, again followed by discussion. We invite your comments or questions at any point. If you have a desk or a mobile phone where you are viewing, you can telephone the studio on 01752 233 646.
Consultation process itself, the actual contact that was made between carer and patient. And even those that were available to analyse showed that most were based on retrospective surveys, which we know to be fallible, where people selectively remember events during the consultation. And that there was clear evidence of known biases in user assessment of the positivity and satisfaction with the care that they receive. So we're now rather less certain about the successes that were claimed in the late 90s. The questions that we need to ask at this stage is to evaluate some of the claims that were made at that point. And one in particular was the claim that the consultation achieved by telemedicine and telecare would be more patient-centred. So we now need to reassess the situation. We need to hold up the consultation to scrutiny as a form of social encounter and check whether the patient-centred model of care actually is achieved. And we have reason to be concerned about this because there are very significant healthcare outcomes that depend on the quality of the patient-carer interaction. For example, we know that patient satisfaction is very much associated with a warm...
Or you could email us direct on tvstudio@plymouth.ac.uk. If for some reason you cannot get through the studio with your telephone call, you could always phone a friend and ask them to email your question or comment. In the studio to discuss their presentations we also have Maria Benalik, who has a clinical background in nursing and in particular in infection control. So over to Fraser for the first presentation.
Hello, my name's Fraser Reid and I'm a social psychologist, and for some years now I've been investigating the effects of mediated communication systems on human communication. So today what I thought would be useful is to bring some of the insights perhaps and some of the questions from psychological research to you today by looking at teleconsultations, trying to draw out some of the implications for human communication in the medical encounter that telemedicine and telecare brings. And I want to start with a report published in 1998 by the Institute of Health Service Management, now the Institute of Healthcare Management, because it was such an optimistic and possibly excessively optimistic report on the potential benefits of telemedicine and telecare for the health service. At that point, it was believed that non-verbal manner and patient-centred attention. We know that patient adherence and compliance to treatment recommendations are a function of their involvement in treatment decision-making. We know too that objective measures of health and clinical status are often influenced by the quality of that relationship. We know that recovery rates post-operatively, we know that pain experience post-operatively are a function of that relationship between the carer and the patient. We know too that the ability of patients to remember and understand medical advice is a function of the quality of that relationship, and perhaps overall we now know that psychological well-being, levels of anxiety, uncertainty about treatment, coping behaviours are all a function of the degree to which patient care is centred around the concerns of the individual patient. So the question we now need to reassess is whether the medium matters. And here we're in a position, I think, to benefit from more than 25 years of psychological research. But one of the key issues to begin the discussion is that we need to understand what Donald Norman calls the affordances of technical systems. The affordances of a communication system will be the degree to which it supports different aspects of